Welcome back to the deep dive. Today, we're tackling something, well, incredibly important. We're doing a deep dive into mastering medical emergencies. And this isn't just abstract knowledge. We're talking immediate, effective, potentially life-saving responses, drawing from materials aimed right at professionals in high-stakes settings like imaging sciences. Our goal here is simple, really. Take this pretty dense, high-stakes subject and boil it down to the absolute must-knows for you on the floor. And let's be honest, the idea of facing a sudden cardiac arrest or, severe shock, the sources say it can be somewhat frightening, totally understandable, but that's where preparation comes in. Awareness really is the key.
Exactly. And for you listening, we're aiming to give you a kind of shortcut, not just definitions, but functional understanding. What must an imaging professional know, and more importantly, be ready to handle, like right now? The mandate from the profession is crystal clear. You have to be sharply aware of those typical signs and symptoms. Sometimes they're subtle. Things associated with head injuries, shock, diabetic issues, cardiac arrest, the whole range. And the sources really emphasize this point. These major events might not happen every single day, thankfully. But they happen often enough that you just can't afford to be unprepared. Which brings us to the core aim of this discussion. An alert technologist, someone who sees things changing and gets help quickly. Well, you might significantly reduce a patient's long-term problems, their morbidity, and you might even save their life. That first moment you notice something's wrong, that can be the absolute difference maker.
That really does reframe the job, doesn't it? It's way beyond just getting a good scan. We're kind of the first line of defense in that moment. Okay, let's dive straight in then, starting with the foundation. The essential professional mindset. The material we looked at is very clear. Just knowing the pathology, the technical stuff, it's not the whole picture. There's this crucial secondary skill.
Yes, and that skill is composure. The literature hammers this home. Alongside the technical know-how, you absolutely need to maintain a calm, confident manner. It's vital. And it's vital for, well, a couple of reasons. First, it helps you think clearly under pressure. Second, it helps prevent the patient, and maybe even other staff, from spiraling into panic. You kind of set the emotional temperature in the room.
I like that idea, that duality. You're managing the physical and the emotional environment, but, thinking clearly when things are hitting the fan. That's easier said than done, isn't it? How do we make that composure practical?
It translates into being methodical, thinking before you react instinctively. And this is where it gets really interesting. The source material specifically warns against rushing. It cuts right against that fight or flight urge. The advice is spot on. Moving too quickly and risking a mistake is not worth the potential harm that might result. It's a powerful statement. What that really implies is your main goal isn't speed, it's appropriate action. If you rush, you might misread the situation. Mix up hyperglycemia and hypoglycemia, give the wrong thing, which could be disastrous. Or maybe you skip a vital check or forget a key detail when you're handing over to the medical team. That first second you see distress, it should be about a quick, calm assessment. Okay, what am I seeing? Who do I need? What's the protocol here?
So that methodical approach, that pause, it really lays the groundwork for the next step, which has to be cooperation and ongoing communication, right? If I rush and mess up, I've already potentially damaged that cooperative effort before the code team even gets there.
Precisely. Your job is to be that calm center right at the start. Gather the facts accurately, secure the scene. The composure you show makes the communication better. It means when you do handoff, the next team gets reliable, calm info, not scattered, panic fragments.
Yeah, that completely reframes what professionalism looks like in a crisis. Okay, mindset established. Calm, methodical, appropriate. Now we need structure. We need to know how to prioritize. Let's get into categorizing the crisis. Major versus minor emergencies. The sources use the severity scale, and it seems crucial for directing our response.
Right. When we talk about major medical emergencies, these are the big ones. Life-threatening or risking permanent damage if you don't act within minutes. The sources list 5 core types you need to be ready for. Head injuries, shock, diabetic crises, respiratory distress or arrest, and the really dramatic one, cardiac arrest. These demand instant recognition, immediate stabilization attempts, and getting that code team activated fast.
Okay, those are the code blues. And then there are the minor emergencies. Still serious, definitely disruptive, but maybe not an immediate life threat unless something else happens, like, say, aspiration or a fall. And the list here feels very practical. Things you might actually see quite often. Nausea and vomiting, epistaxis, syncope and vertigo, seizures, falls, claustrophobia, and issues with wounds.
Yeah, and it's crucial to remember, calling them minor is just about prioritizing the initial response and protocols. It doesn't mean they aren't important or can't become serious. Take nausea, for instance. That awful feeling, often leading to vomiting. If your patient feels that and they're lying flat on the table, the immediate danger is aspiration. Breathing in vomit, that's bad. And nausea is super common in our setting, right? Pre-procedure fasting, contrast reactions. So the response has to be automatic. Turn them on their side, the recovery position, or sit them up if they can. Have a basin ready, maybe suction nearby. That stops a minor thing turning into a potentially fatal airway issue.
Good point. And the other term we should quickly define from that list is epistaxis. Fancy word for...
Just a nosebleed. Hemorrhage from the nose. Sounds minor, but again, you need to know the basics. Tell the patient to lean forward, not back so they don't swallow blood. Pinch the soft part of the nose.
Yeah.
Simple stuff, but knowing the term epistaxis helps you document it clearly or ask for help professionally.
Right. So different categories, different initial steps, but the composure stays the same. Okay, let's dig deeper now into dissecting the critical threats. We absolutely need to spend time on these major ones, starting with the most immediate: cardiopulmonary and circulation issues. Let's begin with cardiac arrest.
Okay, cardiac arrest. It's the abrupt, catastrophic stop of the heart pumping effectively. No cardiac output, no circulation. The patient collapses, unresponsive. Usually no pulse, no breathing. For us in imaging, recognizing this instantly isn't just about starting CPR, it's about what comes next. Often the underlying reason, the thing we need to fix fast, is ventricular fibrillation, or Vfib. Vfib is just electrical chaos in the ventricles. They're quivering, spasming, not pumping anything. The heart's electrically active, but mechanically useless. Recognizing arrest is key because Vfib is the most common culprit in sudden cardiac death outside a hospital, and the only effective treatment for it is defibrillation, an electrical shock.
So recognizing arrest instantly means activating the code and grabbing the AED, because every second counts for shocking Vfib. What does that mean practically, say, if you're mid-scan?
It means preparation and awareness of your surroundings. You see the signs collapse, unresponsiveness first, check safety. If you're an MRI, you cannot bring that AED near the magnet. The patient has to come out first, even if it delays CPR slightly. A flying metal object is a danger to everyone. In a regular room, start CPR immediately. Get them on a hard surface. Send someone for the AED in the crash cart. The stats are stark. Every minute without defibrillation and Vfib, survival drops about 10%. It's a race against time.
Okay, critical info. Now, moving from the heart to the brain, neurological emergencies, specifically cerebrovascular accident, CVA stroke, or brain attack as it's sometimes called. This one's about sudden onset, right? Caused by a blood vessel issue in the brain, a blockage or a bleed. It leads to permanent damage. And the saying is, time is tissue. The imaging department is often ground zero for diagnosis here. We need to spot those signs fast acronym, right? Facial droop, arm weakness, speech difficulty, time to call 911 or the internal code, then get them prioritized for imaging, usually a CT, to figure out, is it a clot, ischemic, or a bleed, hemorrhagic? Because the treatments are completely different, and we're the ones who provide that crucial distinction.
Absolutely. And within our immediate environment, we also need to be attuned to maybe more subtle signs of neurological trouble, like the aura, an aura. It's described as this subjective feeling, or maybe a motor thing, that happens right before and signals the start of, something like an epileptic seizure. It could be a weird smell, a visual disturbance like flashing lights, maybe a strong sense of déjà vu or sudden fear. If you, as the technologist, see a patient experiencing something like that, that's your immediate warning bell. You have seconds, maybe a minute, to prepare. Secure the patient, clear the area around them, get ready for a potential seizure.
And that ties into the broader need to constantly assess the patient's levels of consciousness. It's like a warning track, especially with head injuries. Are they alert, responding to voice, responding to pain, or unresponsive? We're watching for any slide downwards.
Exactly. If a patient who is talking suddenly becomes abnormally drowsy, difficult to rouse, kind of indifferent, which we define as lethargy, that's a huge red flag. It often signals worsening intracranial pressure or maybe a systemic problem kicking in. Being able to clearly state, look, this patient is now lethargic. Half an hour ago they were alert and oriented. That's vital information for the incoming team.
Spot on. And that need for assessment leads us right into the big systemic threat: shock. The source defines shock as this profound state where the circulatory system just fails to perfuse vital organs properly. It's a whole body crisis. This is way beyond just fainting. This is the oxygen supply to the brain, kidneys, heart, everything being compromised. And it's crucial for the professional to grasp that shock isn't just one thing. There are different types, and the treatments can vary dramatically. We usually break it down into 4 main categories. First, there's hypovolemic shock. That's from low fluid volume, usually severe bleeding, internal or external, which we call hemorrhage or maybe extreme dehydration. You see this a lot in trauma. Second, cardiogenic shock. This is when the heart muscle itself fails as a pump.
often after a massive heart attack.
Okay, low volume failing pump. What are the other two?
Third is obstructive shock. Here, something outside the heart is physically blocking blood flow. Think a large pulmonary embolism blocking the lung arteries, or cardiac tamponade, where fluid fills the sac around the heart and squeezes it. And fourth, which is super relevant for us in imaging, is distributive shock. This is where blood vessels dilate massively, dropping pressure. This umbrella includes septic shock from overwhelming infection, or the one we worry about with contrast, anaphylactic shock, that severe allergic reaction.
So the signs might seem similar. Initially low blood pressure, maybe confusion. How does the technologist on the floor begin to differentiate? A trauma patient might look like someone having a contrast reaction in some ways.
They often do overlap, yeah. Low blood pressure, rapid weak pulse, maybe fast, shallow breathing. Those are common to most types. But the skin can give you a big clue. Think about hypovolemic or cardiogenic shock. The body's trying to save the core organs, so it clamps down blood flow to the limbs. The patient will likely feel cool, clammy, look pale. We call that pallor. That's classic cold shock. But in early septic shock or neurogenic shock, the vessels might be wide open. So the patient might actually feel warm, look flushed, maybe even have dry skin. That's warm shock. Observing and reporting the difference cold and clammy versus warm and flushed is really valuable information.
And prevention is key here too, right? The sources talk about managing anxiety, keeping patients warm, comfortable, screening carefully for allergies before contrast. These aren't just niceties, they're actually part of shock prevention.
Absolutely. Keeping someone warm with a blanket, talking calmly to reduce anxiety. That basic human care can genuinely help prevent things escalating into, say, neurogenic or even cardiogenic shock if they're already stressed. There's that holistic view again.
Right. Let's move into section 4, metabolic and sensory disturbances. This is a really critical area, especially with diabetic patients, because you've got these two opposite states, both really dangerous. Why is telling them apart so vital?
Because confusing them could be fatal. You have to know the difference between hyperglycemia and hypoglycemia. They need opposite treatments. Okay, hyperglycemia. That's abnormally high blood sugar. It usually develops kind of slowly over hours, maybe days. It can lead to diabetic ketoacidosis or DKA. The patient often feels really thirsty, needs to pee a lot, might have that deep, rapid breathing pattern, small breathing, and sometimes a fruity smell in their breath. This patient needs urgent medical care, IV fluids, insulin. You need to get them transported.
And the flip side?
The flip side is hypoglycemia. That's abnormally low blood sugar. And this one often comes on fast. Maybe the patient took their insulin, but then had to fast their scan and missed a meal. This is the one the technologist often needs to treat right there, right then.
So what are the signs for low blood sugar?
Look for weakness, sudden sweating. Maybe they get irritable or confused, start slurring their speech. If you see that, think hypoglycemia. And if they're conscious and can swallow, the immediate treatment is sugar, juice, glucose tablets, even regular sugar packets.
Don't hesitate. Delaying that sugar can lead to seizures, coma really quickly, so the key difference is often the speed. Hypo is fast, often needs immediate sugar. Hyper is slower, needs advanced medical help.
Exactly. Knowing that distinction is probably one of the most practical, life-saving things you can carry in your head.
Okay. What about other temporary consciousness issues? We have syncope and vertigo.
Right. Syncope is basically fainting. A temporary loss of consciousness because of a brief drop in blood flow to the brain, often triggered by low blood pressure or sometimes a strong emotional reaction like the sight of blood, the classic vasovagal response. Usually they come around quickly on their own. But the big danger during the event is the fall, hitting their head, breaking something. Your immediate job is safety. Protect them from injury as they go down, then get their feet elevated, Trendelenburg position, if possible, helps get blood back to the brain. And related, but different, is vertigo. That's not fainting. It's the illusion of movement. Feeling like the room is spinning or like you're spinning. It can cause terrible nausea, make it impossible to hold still, and increase fall risk. Again, it's about safety, repositioning, helping them feel stable.
And just to hammer home the point about neurological signs, let's revisit lethargy. That abnormal drowsiness, stupor, lack of interest, seeing that develop in a patient who was alert earlier, especially after trauma or contrast, big red flag, needs immediate attention. Okay, we're moving into section 5, procedural preparedness and technical concepts. We've talked a lot about recognizing problems. Now let's focus on the doing. What are the core life support actions and tools we absolutely need to be proficient with?
Well, the absolute bedrock is cardiopulmonary resuscitation, CPR. That's the artificial substitute for heart and lung function when someone's in cardiac arrest. You need to know the current guidelines, high-quality chest compressions, rate, depth, the 30.2 ratio usually for adults, but also the logistics in your specific area. Like if the patient arrests on the CT table or in the MRI bore, you have to get them onto a hard, flat surface, usually the floor or a backboard fast, or your compressions won't do anything. And think about angiography suites you might be doing CPR under fluoro. You need to be aware of radiation safety for yourself and the team, even during resuscitation.
And CPR goes hand in hand with the automatic external defibrillator, AED. These devices deliver that crucial electrical shock. We really can't stress this enough, can we? If the underlying rhythm is Vfib, CPR keeps things going, but the AED is what can actually fix it. So training isn't just about finding the AED, it's about being confident, slapping those pads on correctly, listening to the voice prompts, analyzing rhythm, do not touch the patient, shock advised, and making absolutely sure everyone is clear before you hit that button. The good news is the AED is designed to be used by people with basic training. It won't shock if it's not needed. Your job is just getting it there and using it quickly and safely.
Beyond CPR and AEDs, we also need to be ready for trauma, especially internal injuries. And what's really interesting here is how our sources highlight assessment tools that actually use imaging at the point of care. Specifically, the FAST acronym, right? FAST. That stands for Focus Assessment with Sonography for Trauma. It's a quick ultrasound exam done right at the bedside on unstable trauma patients. The goal is to rapidly look for internal bleeding. You're trained to quickly scan 4 key areas: around the heart, pericardium looking for tamponade; around the liver, Morrison's pouch; around the spleen and down in the pelvis, looking for free fluid, which in trauma usually means blood.
And why is doing the FAST exam so vital? Maybe even before they get to CT. It's all about deciding urgency, especially surgical urgency. If that FAST scan is positive, if you see significant free fluid in one of those spots, it often means the patient is too unstable for a potentially lengthy trip to CT. They might need to go straight to the operating room. It's a critical triage tool in those first few minutes. Does this patient have life-threatening internal hemorrhage, blood-escaping vessels that need surgery right now? FAST can help answer that incredibly quickly.
And the trauma discussion naturally includes general wounds, physical injuries disrupting tissue. While we're not usually managing complex surgical wounds directly, we are removing patients who might have them. So we need to be aware of potential complications, especially wound dehiscence. That's when a surgical wound starts to separate. It could be just the top layers, or it could be complete, where internal contents might even protrude. That's called evisceration. If you're moving a post-op patient and you see that happening, stop immediately. Don't push or pull. Cover the area gently with sterile gauze, preferably moistened with saline if available. Keep the patient calm and get urgent surgical help. You don't want to make it worse.
Definitely need to be careful there. Lastly, in this section, because we use contrast agents so often, we need to be sharp on recognizing allergic reactions, starting with skin signs like erythema and urticaria.
Okay.
Erythema is just redness of the skin, can be from lots of things: irritation, injury, often minor, maybe goes away quickly. But then there's urticaria. That's hives, and that's more concerning, isn't it? Yeah, urticaria is a vascular reaction. It's those raised, itchy welts. It means the body's immune system is kicking off a response, often involving histamine release. Seeing hives pop up, especially right after contrast, that's your first major warning sign of a potential systemic allergic reaction starting.
Absolutely. Spotting urticaria, even if it looks mild, is critical. It means the allergic cascade might be underway. That allows medical staff to jump in quickly with antihistamines, maybe steroids, to hopefully stop it progressing to more serious things like throat swelling, laryngeal edema, difficulty breathing, bronchospasm, or full-blown anaphylactic shock, which is a major emergency we talked about earlier. So watching the patient's skin, asking how they feel, monitoring their breathing, pulse, especially during and right after contrast, it's just non-negotiable vigilance.
That really covers the spectrum, doesn't it? From skin redness all the way to using ultrasound to find internal bleeding. Okay, let's move to section 6, the emergency toolkit and environment. Knowing what to do is one thing, having the gear ready is another. Let's talk about the physical tools.
Right. The professional absolutely needs to know about the emergency cart or crash cart. You need to be able to explain its purpose and generally what's inside. It's basically a mobile mini ER. It's got the essential drugs, epinephrine, atropine, things for allergic reactions, airway supplies like intubation equipment, IV start kits, and it should definitely have the AED readily accessible if not stored directly on it. The really crucial thing the sources emphasize about the cart is standardization and readiness. Everyone needs to know exactly where it is. It usually has a lock or a seal that breaks easily, so you know it hasn't been tampered with. And it must be checked regularly daily in many places to make sure nothing's missing, nothing's expired. Imagine needing epinephrine in a code and finding the vial empty or out of date. The liability and the risk to the patient is huge. Standardization also means if staff float between departments or come from elsewhere, they know the basic layout.
Makes sense. Total readiness. Now, one last point about the environment, something particularly relevant to imaging suites, especially MRI, claustrophobia.
Yeah, the source defines claustrophobia as that extreme fear of enclosed spaces. Now, it's not a medical emergency like shock, but it can definitely become a situational emergency in our environment, can't it? A full-blown panic attack triggered by being in the scanner, that can escalate fast. The patient might thrash around, try to get out, potentially hurting themselves or damaging really expensive equipment.
Absolutely. Managing this takes real skill, that composure we talked about, and ideally preemptive action. Talking the patient through it beforehand, explaining everything, offering distractions like music or using prism glasses so they can see out, constant verbal reassurance. Sometimes, if it's severe, it might involve premedication or sedation discussed with the referring physician. But if someone does start panicking badly in the bore, your immediate priority shifts to safety, getting them out safely, even if it means stopping the scan. You have to prevent injury. That feels like a really thorough journey through the demands of managing these situations. A lot to take in.
It is. So if we boil it down, what does this all mean for you, the learner? We've really hit on three key pillars of preparedness. First, the technical knowledge. Knowing the conditions, especially differentiating the really critical ones like cardiac arrest needing an AED versus, say, hypoglycemia needing sugar. Second, procedural readiness, being able to perform CPR correctly, use the AED confidently and quickly. And third, that crucial professional composure. Staying calm, thinking clearly, resisting the urge to rush, which prevents errors. Mastery isn't about becoming an ER doctor overnight. It's about being that skilled initial observer, accurately spotting those first signs, the subtle skin changes and shock, the sudden lethargy after an injury, and then starting the right sequence of actions, calmly and correctly. You really are that vital first link in the chain of survival.
So, to wrap up, maybe a final thought for you to consider, building on what we've discussed. The sources really frame this preparedness as being that critical connection. You're the person there when crisis strikes, bridging the gap until the full medical team arrives. That gap might only be seconds or minutes long, but it's often the most critical window. How does knowing you hold that responsibility change how you might react? How does it shape your immediate actions when you see that first flicker of an aura suggesting a seizure is coming, or notice that sudden clamminess that screams shock? Think about those specific signs and symptoms we covered, because being alert, being ready, it isn't just part of the job description. In those moments, it might be everything.